I'm not even caring about the food part. Like that didn't even, everyone's like, oh my God, that has to suck that you're on liquids and now you're on periods. I'm like, actually, that part doesn't bother me at all. It's literally the fact that I can't just do the normal shit that I'm used to doing every day, has gotten to me. And Dr. D, you're gonna laugh. Last Friday, I had a little bit of a meltdown. My mom came over because I was just like so tired of not being able to do the things I like to do. And I looked at her like, if Dr. D just wasn't so good at her fucking job, that I wouldn't have had to have the surgery. And she's like, but you needed it. And I'm like, I know, but it's just like, damn, like this is like, I got humbled, I got my ass put back in the chair and was like, no, you need to chill out. You need to calm down. So it's interesting. This recovery has really taught me a lot. Especially now that I know what things are.
Hey, it's Mel. Before we dive in, just a quick note. This podcast is for educational and informational purposes only. The insights shared by our guests are not a substitute for medical advice, diagnosis, or treatment. Always consult with your healthcare provider before making changes to your diet, exercise, or lifestyle. Now let's get to the show.
Welcome back to Our Sleeve Life podcast, and I am your host, Mel. And today is going to be interesting. You need to be on YouTube. You need to go to Our Sleeve Life podcast right now on YouTube and look at this because they're going to show all of my insides. I have Dr. Dovec and Hannah from Body by Bariatrics with me because I got revision done, guys. If you haven't been watching, I went from VSG to RNY, and there were some things in there that we were not expecting. So welcome to the show, Dr. D and Hannah.
Thank you. Yes, we are really going to get to know you inside and out today, Mel. As you said, we're going to be looking at your actual OR footage of your actual insides, unedited, uncensored, everything. So this is one of those ones, if you are listening, you'll get something out of it, but really to see the visuals of what we're talking about is going to be very helpful for those of you following along.
Yeah. So for those that don't know, I have been secretly puking once a week of bile. I really that's just kind of how I live my life. It happens, things happen to me. I just keep moving. So, and it's kind of crazy. I literally went to the butterfly effect event that they threw on. And then we got to talking, they got on the podcast, and then she diagnosed me live, guys. And legit, I think it was 3 weeks, maybe 4 weeks at the most later, I was in her office and getting surgery because you're not supposed to puke at all. I even asked her, like, what's normal puking? Nothing is normal. So I did not realize that. So once a week, if you're doing that, it's not okay. It's not good for your insides. Also, a lot of us, I've gotten messages already being like, I thought it was my GLB-1 too. And people are getting checked. A couple of my benchies already got checked. One of them found out they had ulcers in their stomach. The next one has an endoscopy that's actually scheduled for next week. So we're going to find out about her. So get checked, guys. This is very important. You should not be puking. You should not.
Yes. So we have a mini little series as we've been sharing on our Instagrams and Facebook, TikToks, YouTubes. It's already 8 parts as we record this, 8 little mini videos that are describing the behind the scenes and just little quick snippets. Today we're going to go all in. Like I said, we're going to go from start of the case to the end of the case. I'm going to point out some of your other anatomy, your uterus, your intestines, your liver, your spleen. I'm going to talk about all of those insides and how they look.
I love that.
And as part of that series, I think people are really surprised by your journey and how it resonates. So I just want to say, first off, thank you so much for sharing. I know you shared everything from how you felt early. It is still a surgery and just the recovery process to now you are a couple of weeks out. So how has it been, just overview before we kind of dive into this footage?
Yeah, so I'm 17 days as of today. And it's been up and down. It's really, I didn't realize how emotional it was gonna be. I forgot about that part. Like, I remember now, back then, like, oh shit, yeah, there was lots of random crying moments.
Yeah.
But like the healing has been great. Like every day it's a little bit better. And as of today, I can sleep on my stomach. I can go on longer walks. I don't feel any pulling on the right side anymore. That is so nice. I'm not even caring about the food part. Like that didn't even everyone's like, oh my God, that has to suck that you're on liquids and now you're on periods. I'm like, actually, that part doesn't bother me at all. It's literally the fact that I can't just do the normal shit that I'm used to doing every day, has gotten to me. And Dr. D, you're gonna laugh. Last Friday, I had a little bit of a meltdown. My mom came over because I was just like so tired of not being able to do the things I like to do. And I looked at him like, if Dr. D just wasn't so good at her fucking job, that I wouldn't have had to have this surgery. And she's like, but you needed it. And I'm like, I know, but it's just like, damn, like this is like, I got humbled, you know, I got my ass put back in the chair and was like, no, you need to chill out. You need to calm down. So it's interesting. This recovery has really taught me a lot. Especially now that I know what things are, like when I didn't know what the gas pains were the first time around. So now like I can feel them and now I go, oh, we just need to get up. So it's like, I'll just pace my house until I don't feel it anymore. So it's cool because I now know what things are doing. Like, and now that you've even shared one of the parts where you actually tell us like what you did, like the graphic of a sleeve into a bypass, like I can feel those little areas in the beginning. Like I could feel when like stuff would hit them, like the different food and liquids. I'm like, oh, now we're at the core here where now it's going from the pouch to like in my intestine, and now we're over here to this side where she did work. I'm like, oh my God, this is crazy. So it's been wild. It's just such a wild feeling.
I love it. Well, without further ado, let's
see.
We have Hannah here too, who was actually in the operating room.
Yes. So
yeah, she took care of me afterwards too.
I did. I tried my best, and then I was like, great. I had to leave a couple times, and I was like, oh God, poor Mel. She's just like,
yeah. I'm not one of your cheery ones that come out after 30 minutes. That's not Mel at all. I'm very groggy and kind of out of it. So, but I remember just like seeing Hannah and just being happy that I knew a friendly face.
Yeah, it was. I was saying this before we got on, but I was like, I went out and you were kind of like groggy. You're like, where am I? I'm like, you're at the surgical institute. You just had surgery. You're with Hannah. And you go, I like Hannah. It was very sweet.
It's so crazy. Oh God, what are we in now? Okay, guys, we get on.
Let's pause for a sec. Let's pause. All right, well, let's do it. Let's go inside of your abdomen. So the first thing, I'm actually looking in your pelvis. So I'm looking down, which is not in the turf of the surgery, but I wanted to first point out your uterus. It is cute, but you do have probably a little fibroid inside of your uterus.
Okay.
And you see these little black spots. They kind of look like cigarette ash. That's how they're characterized. This is endometriosis.
Oh,
you actually have some endometrial or uterine lining tissue found outside of your uterus, which is what endometriosis is. So if you ever had really heavy periods at any point in your life, this combination of a fibroid and endometriosis is absolutely the culprit.
My goodness. So the fibroid, like, does that ever go away? Like, how does that work?
No, so the fibroid wouldn't go away if it really bothered you. If you had periods that were causing you to have maybe significant anemia and iron issues, you might want to take it off. They can even try to go in through your vagina and through and look and try to scrape and do a myomectomy. They can try to do that to get the fibroid out. Or if it enlarged or it was really bothering you and all of this, you could always have a hysterectomy, which is where they would remove the uterus. A total hysterectomy is where they would also remove this right fallopian tube and left fallopian tube and both of your bilateral ovaries. And they would probably take off some of this endometrial tissue here off of the side wall of your pelvis as well.
My God, this is
You don't need to have it, so don't worry. No more surgeries.
No more surgeries. I think I'm a little bit of a baby with surgeries. Like, I'm like, my hand still hurts from the IV. I'm not going to lie. I'm like,
honestly, a lot of people tell me the hand is the worst and most long-lasting part.
Yes. Oh my goodness, ladies.
So what we're doing now is we're putting in more trocars, or basically we're putting in, that was a little needle that I'm putting in some numbing medicine. So I'm numbing up your muscles, your lateral muscles there, to make sure that whenever I'm putting this trocar in, it's all good there. So I'm going to put in 4 total trocars, which
Okay.
are what the instruments and the camera will go down into. The trocar
Oh,
I'm putting in right now, that is going to be for the assistant's right hand. And I'm coming out, I'm cleaning the camera, I'm going to look around, and I'm going to fast forward here to the start of the actual operation after I have all 4 of those trocars in there ready for action. So I want to go back here a little bit just to show you what your insides look like. So you see here, I'm lifting up. That is
yeah,
the
what is that?
transverse colon. Do you see this little bit of fat right here? That's your omentum. People's omentums are thick, heavy kind of coverings.
Yeah.
You barely have any fat at all. You barely have any
Yeah.
intra-abdominal or visceral fat.
Like literally,
Oh
I
my
was in the OR for this, and she's like, "Oh my God, she has no fat." She's like, "There is nothing here." Like
God,
literally, she's like, she is so skinny on the inside.
this is
Like it was wild. Yeah.
crazy.
It's so wild. You're so healthy, so beautiful. And even you can see these vessels here. So this thicker yellow, this is called your mesentery, and this houses the arteries and veins that are the blood supply, the vascular system to your intestines. And yours are you have so little fat, you can see the vessels. You can never see the vessels, never. And that is because you had the sleeve, and then ultimately you've been on GLP-1s, and that means your insides are the most superb health possible. So what I'm going to first start off by doing is I'm making the lower connection, and I'm using this device. It's an endomechanical device, a stapling device that will staple, seal, and separate the tissue. So everything that's going to be to the left of the stapler, that will be your biliopancreatic limb, and everything to the right of the stapler, that will be your roux limb. So we're going to fast forward, and then I'm going to actually put a stitch or a suture to mark what will become the roux limb here. So a little bit of that beautiful blood supply. I'm just going to cauterize all of that. All right, so what I'm going to do now is I am going to suture so that I'm marking what my assistant was holding there. I'm going to get this little piece of intestine, and I'm going to sew a suture onto the tip of it, and that will allow me to both mark it so that I know that's the part that's going up top, that's going to join with that stomach pouch to make that upper anastomosis or connection. And it also is going to act as a handle for my assistant to use. What I'm doing now is I'm going to count downstream, and I'm counting 150 centimeters. So my assistant, you see there's a little piece of intestine that's suspended in the air. That
Yes.
is, again, what we call the biliopancreatic limb. That is the part that is connected to the bypass stomach in that first part of the small intestine where digestive juices are still kind of coming downstream. And then this part that I'm counting, this is the part that you'll swallow food in the intestines. Things will go down this. This is where food and drink goes down into the part that I'm counting. So what I'm
Lord.
doing now is I'm on what's called the roux limb, and I'm having my assistant hold that up in the air, and I'm going to make what's called a small anerotomy, or a hole in the side of the small intestine, because I'm going to now join the side of the small intestine here to the other side of the small intestine to make a connection between the 2 parts of the small intestine, the jejunum and the jejunum. So that's why this one's called
The
a JJ
JJ.
anastomosis.
Okay, the
So I made
JJ.
a little hole here, and now I'm making a little hole in what's this blind end of the biliopancreatic limb. So this way, everything's all connected so that your mouth, when you swallow food, will ultimately connect all the way down and out into your colon and out of your body. So I'm making these 2 little holes here, and now I'm going to use a stapling
Oh my
device
God.
again to join them.
That is wild. So that's why I can feel like things just kind of like drop. Like I felt like once like a little I would take a drink of something and then it was like slow and then it was all boom. Like I could feel it.
I don't think
No?
so because it has to go through. You saw me counting and counting and counting. It went through 150 centimeters of
Oh,
intestines. So
first.
that's
Okay.
kind of a misconception that you would feel it. That's not what you were feeling. Things like going through that quickly.
Okay.
It's still absorbing and that sort of thing.
Yeah, this is also like I have watched the surgery multiple times, not your surgery, but watched bypasses before and talked about it before. It is still so confusing, all of this, like to see it in 3D too, and like versus the 2D image that you see. So it's really like I'm always like, wait, but it's interesting. It's always cool to see.
It's wild to see my insides you're just pulling and moving and
Yeah.
What I wouldn't give to see my insides in this high def
Oh my God.
4K. I would
She's
love to
just gonna
see.
do a laparoscopic.
I should have Diana do
just
one.
a
Dr. Lane.
Dr. Lane do it for you. Oh my
Yeah.
goodness.
Diagnostic.
Yeah, that's an unindicated procedure
Yeah.
undergoing anesthesia
Anesthesia.
for no real reason. That's
Yeah.
probably a good idea. So yeah, I'm sure you want to wake up and do that. But right now what I'm doing is I am so I fired one direction.
Okay.
And so now what I'm going to do is I'm going to use this as a handle, and it kind of just reinforces that crotch of the staple line there. And now I'm going to put I'm going to go the other direction. It's a bi-directional firing. So I'm going to now swing this thing around. Swing it around 180 here, and then I'm going to fire it the other way. So I'm going to fast forward a little bit here. And we're putting the suture in, and I'm just going to use this as a handle again to kind of swing it around. And then here we go. All right, so my assistant is doing it the other way. Now here comes the stapler. This way everything's nice and wide open, so that this is again the place where those food and drink that you ingest are going to meet up with the small intestine for the first time.
But so just to clarify that this connection is coming from the retained stomach and where all the juices are going to come through. And then later we're going to connect the stomach.
Exactly. So
Yeah.
the stomach
Okay.
is going to be connected to when I originally put that little suture on that small intestine, that's that. And so now I'm going the other direction. Up, looks beautiful. Yay.
Oh my God. That
You
looks
want
so
it,
wild.
yeah, you want it to look, there's a certain way you want it to look. I'm like, oh, this is a good anastomosis. Okay, so now I checked the backside and made sure I didn't do any holes or any issues. And now what I'm going to do is I'm going to ultimately staple off that tip here. So I'm putting in a suture to kind of suspend or hold that up, and then I'm just going to staple right underneath of it. So you see that little hole here? I'm
Yeah.
actually going to just staple that off so it's a completely airtight seal. There's no leakage or holes. And this is also when we've had conversations about early post-op complications. One of them can be a leak, and a leak happens when the GI tract, which is really dirty, obviously food ultimately goes out and becomes stool. It's when that GI tract, unfortunately, there's a connection or hole in one of these staple lines, and some of that gets into the very clean or sterile environment of the abdominal cavity. And so that's what I'm going to prevent from happening.
So I don't have any obviously leaks, but can you explain to someone what they would feel or need to be looking for if they think they have a leak?
Absolutely. A lot of people are like, well, how will I know something's wrong? You'll know. You will know.
Right? Yeah.
There's no two ways about it. You already said in the beginning of this podcast that you understood, like, oh, I know now what gas pains are like. I knew it was gas. I knew I just needed to get up and walk around, take a gas X, take it easy, sit down. This is an unrelenting stabbing pain that is just like, this ain't right. This feels like I have this sensation of impending doom, where
Oh,
you
okay.
and you can just very focally, it's a stabbing pain. It's not a dull pain or a gas pain.
Okay. Okay, guys. So make sure you understand that it's going to be stabbing. You're going to know right away. Like I have had the normal sore pain and then the gas pain. And they are different. You can definitely tell the differences once you know what you're looking for. So like gas pain, I felt like it was more like in my back and my shoulders. Once I started moving around, things were a lot easier. And so that's how you know like the walking's working. The soreness was definitely more on the side that she had to do that muscle repair and give me that extra stitch. So like it was never sharp pains. It was more dull or a soreness that I had.
You got it. And right now, I cut off right underneath of that hole from where they connected. So that's all sealed up really nice. It looks good. That's a wide open area. And your JJ anastomosis or jejunal is now complete. So now what I'm doing is I'm just checking to make sure I didn't twist anything and that honestly your mouth will be in continuity with your anus pretty much is what I'm making sure right now. I'm making sure that I'm giving you a Roux-en-Y, not a Roux-en-O. A Roux-en-O would be things go down to that connection and go right back out your mouth. So
God,
this
that
would go
was so.
straight down. We want things to go straight through. So I just was double checking that your anatomy was perfect.
So
And
what is the yellow next to my intestines? Like what is
that is the mesentery that has those blood vessels in it that are feeding the arteries and veins, the vasculature that are feeding your intestines.
Okay.
Now, what I'm going to do now is, do you see how there is this big space here? This big hole. So you hear sometimes that patients can get bowel obstructions.
Yes.
They can have something called an internal hernia. So an internal hernia would happen if this is it's called ethibond suture, which is basically a permanent suture. So what I'm doing is I'm obliterating this hole by closing this entire space, so that will prevent intestines from sneaking into this space, getting stuck or incarcerated, and then that would cause them to sometimes kink, and that would require another operation to get them out down the stream. So I know you came from Oregon. I do this for every patient, obviously, every time, but I want to make sure that you have no problems in your neck of the woods ever. So I'm taking very small bites here with this needle of your mesentery, and I'm pulling or I'm purse stringing this hole together here really well so that space, that potential hernia spot where things could kind of get stuck or go into where they don't belong, I'm going to obliterate that hole completely.
Oh my God. And what happens to the sutures and the things that you're using?
So the suture that is green, this is the one of 2 times that I'm going to use this suture in your surgery. These will always be there because I don't want them to absorb. I want this suture to always remain because I want this hole to always be closed. If I use absorbable sutures and that pop back open, then your intestines, these little squirmy little peristaltic little beings, sometimes would try to go back in there. And it's because you're so dang skinny, I had to actually go, those last 2 sutures I just did, I don't normally have to do, because normally I would have pulled through, but I wanted to make sure that that little fat that you have there of the mesentery, that hole is going to come nice and tight and closed and together.
Oh my goodness.
Sorry, I was a little eager to make sure that I got that thing down tight.
Yeah, you were.
That space now is completely obliterated. So this is your JJ mesenteric potential internal hernia spot, and you see that I closed the door on that bad boy. You can see how that hold up. Now you see it. Now you don't. You can see that that's all pulled together.
That's wild. Okay, and so I could have had a hernia if you didn't do that. Like another one?
Yes, and normally that would not happen until down the road. And the symptoms for that would be nausea, vomiting, because the intestines could kind of go into that space, and then if they get stuck, they could get kinked off. And so then everything, it's like plumbing. If it's like you have a clogged drain, everything would then come back up.
Okay.
All right, so everything is done there. So we're all completely done with the bottom part. And now what I'm doing with the table positioning, you were completely flat on the table. And now what I'm doing, you're going to see things sort of start to shift and move. We're actually changing the table position to what we call reverse Trendelenburg. Okay, here's your fat. There's like no fat. Look at this.
Yeah.
I'm about to lift it up, about to divide it.
There's the stomach. That's weird.
What is that you're holding up?
So that's called your omentum. So that's the only bit of fat that you have, that's it. And if I know that you're not a connoisseur of fats like I am, but most people's intestines, it's so heavy and thick and full, and it takes me a good few minutes to divide yours. Okay, that was a good, 3 seconds? And yours is completely divided in half. That's all the fat you had.
Oh my God, that's really cool.
The fatty apron that covers your intestines, and yours isn't really covering anything, as you almost have no omentum. So now your position is in reverse Trendelenburg. You're standing completely up. And as Hannah just said, this is the part, my friends, that I want to make sure that you guys watch. This I was not expecting at all. Mel, oh my God.
I
Your
know.
stomach is complete. You see you have some clips here?
Yeah.
So I use clips too. As you saw, I just used some clips. I don't think clips are a bad thing. But because the clips have caused your staple line to rotate and get stuck to your abdominal wall. That's your abdominal wall there. You see your heart beating right here. That's your diaphragm. That's your abdominal wall, the final layer. And your stomach is completely kind of corkscrewed, turned, twisted, and it's now stuck up to the abdominal wall. We were like,
is this something you've like seen before?
oh yeah, I've seen it before.
How does this happen? Everyone has asked me online and my family, like, how does that happen? Like, how do I get attacked?
Your body, the way that the sleeve is, it is really big and boggy. And I don't know if it was the clips or what, but it caused, see how that should lay like this. And yours was completely
suspended.
What if it was even like kinking?
It was kinking.
That's why it would get the bile reflux.
No wonder.
You
oh my
see
God.
how it is totally corkscrewing. So I see this, but almost always people are banging on my door. You were like, oh, I guess this is like normal. So that's the most mind-boggling thing.
That is the most mind-boggling thing.
Okay, look at your hernia. Look at your hiatal hernia. So it's hard to appreciate, but you see how this is like can you appreciate how that's like a hollow
oh my God.
Hannah, help me describe this.
It's like if you had saran wrap and you put it on something warm and it like suction down into it. I don't know if you've ever done that. It kind of looks like that.
That's a good one.
You know, so it's like it's pulling almost. Because it is interesting because you're always like, oh my God, look at this hernia. You'll send us pictures and stuff. And I'm like, yeah, that's crazy. Whoa. No, and then Dr. Lane though is like, oh my God, that's the craziest thing I've ever seen. So it's hard to kind of we don't see this all the time, but yeah, it's like it's like it's suctioned up almost into the chest, the wrong place.
So that was like in my esophagus, basically. Like it was like
your esophagus and some of your stomach were the entirety of the stomach and the bottom part of the esophagus. When you're made, are supposed to be in your abdomen. And then when you see this kind of like indentation into the diaphragm, this sort of like she's saying this suction up.
Yeah.
It ain't supposed to be like
it's not
this.
Supposed to be there.
So what I'm doing right now is I'm taking off the attachment. So everything right here, this like pinkish, that's your sleeve stomach, which is humongous. I know I keep saying that, and I hope I'm not making you feel bad because it's like, all right, we get it. Great. My sleeve was kind of jacked up and it wasn't done right in the first place. And I know that it's like, well, that's certainly discouraging.
I feel like it should be like validating though, more than anything.
This is insanely validating. Like,
okay, good.
All the symptoms I've had over the years, like this just makes way more sense of what I was feeling and how I was feeling.
Yeah.
Because I am, guys, for those that don't know, I am 11 years out from sleeve, and now we're doing the bypass because I was having all these random things, but just acting like it was normal.
Yeah.
When it's not.
And even like a lot of like your weight loss, like your sleeve is 3 times the width it should be. And I'm going to really be able to show you that because you know now, I mean, you know SLP, I've shown you, what sleeves should look like, just from the picture,
Yeah.
And when you see this, whenever I splay it out, I know you've seen the piece that I took out on Instagram and I showed just that piece should have been removed the first time. That to me makes me like, it's so like kind of emotional and upset for you and any kind of the weight loss journey portion of this.
Yeah, because like I've only hit my goal weight once. And that was like last year. Right. And that was literally year 10. Isn't that wild? Like, and this makes way more sense why.
And I bet you're going to lose a fair amount of weight from this because you should feel more restriction now.
Okay. Yeah, I'm already down 3 pounds. Oh, not 3 pounds.
Weighing yourself.
I thought that you were down even more than that.
I'm more than that. I'm down 7. Sorry.
Yeah, that's
down
what I
7
thought.
pounds. Yeah.
Yeah. I mean, you can tell you already are like you look.
Yeah, you can see it even.
So, I know some people have been messaging me and be like, are you down 20 pounds? You look like you've lost like 20. And I was like, I'm not, but thank you. I'm down 7 as of today. I weighed in and I'm down 7 pounds.
So
So,
that's crazy. You're losing so much faster than most revisions are losing. That's also a testament to your first procedure just being so wide. Look how much stomach there is. There shouldn't be any of this. So basically what I'm doing right now, I'm doing a lot of the dissection. So I have to take off the yellow there is your kind of omentum. That's all scar tissue. That's all
Okay.
things that are like stuck to the sleeve that I have to get the sleeve completely kind of uh I have to get it completely cleaned off and dissected.
isolate.
So yeah, like isolate so that I don't see anything else on it. So I got to get it in its bare form here. So I'm going to fast forward a little bit there. And now what I'm doing is I'm starting on the hiatal hernia part. So,
Oh, sorry,
oh,
before
go
you
ahead.
start with the hiatal, could I have caused myself to have a hiatal hernia?
No. Your sleeve did. It's the
Let's see.
physiology of think about it. Something chronically, first off, yours is twisted, so that's pressure, backing up, backing up, backing up. The regurgitation, it's a muscle, and it's just going to weaken over time when things are just constantly going back up the wrong direction. That made you have a hole in your diaphragm for the esophagus to come down and ultimately become the stomach when it goes through that hole in the diaphragm and goes into the abdomen. So that hole, that muscle around there with time weakened, and that makes the hole bigger and things suction up through that hole, like your stomach, and all of your esophagus was up in there too. God, your
Yeah,
stomach is so pretty.
the main reason too I asked is because there's been two incidences in the last 10 years. One was 2 Decembers ago where I got that like crazy COVID slash Megatron, whatever you want to call it, COVID. So
Okay.
where like I was out for like legit 13 days, didn't leave my house. And I puked so hard that I started puking blood. And so my Aunt Nini was like, this is blood. If you puke one more time, we're taking you in. And I didn't puke again, blood after that. But I
Mm.
was like wondering, like, did that cause anything? Does that make things worse? Um,
Sometimes I do think that the violent vomiting can weaken that a little bit, but that's normally more my theory in like the early post-op period.
okay.
I mean, it wasn't that was not like the one and only offense that caused it in that moment. It wasn't like
Right.
that.
Okay.
It might have,
It wasn't helping
it
anything.
wasn't helping. Yeah,
Yeah.
yeah, but so you can see like this is a chronic thing over time.
Yeah.
Wow.
And what I'm doing is I'm mobilizing your stomach to get it back into the abdomen. And you can see a little bit here to screen left right here. That's your esophagus right there. And then I'm taking some attachments off of this area called the angle of His. And then I'm basically just like again dissecting and cleaning all this up. Okay, so we're back in and I put that thing in there. That's a Raytech that I put in there just to dab any just any oozing or bleeding just to make sure that the tissue planes remain as beautiful as they are so I can see kind of where I'm going and what I'm doing here. So now I'm starting to get some of your esophagus. That's what I'm lifting up on. I'm getting some of your esophagus from up in your chest now intra-abdominal. I'm getting it inside of the abdomen.
And just
Whoa.
for watchers, this is the liver right there.
Ah,
Yeah,
yes.
off on the left side. So something that's different, a little different, I feel like with you guys is you don't usually use like a liver retractor.
Thank you for bringing that up. Actually, I would use a liver retractor probably 99% of the time when I'm doing a big hiatal hernia repair like this. In your case, yours was a type 3 paraesophageal hernia. But because your liver is so skinny, it's like almost like a stingray. It's just so thin and beautiful and healthy and the correct color.
Aw.
There's no nodularity, there's no thickness, it's not orange, it's not fatty. There's no what we call NASH, which is non-alcoholic steatohepatitis. You have nothing like that. I can actually like with my left hand, I'm just kind of like barely like
Like,
flinging this little thing to the
yeah.
side.
Yeah,
So
because
now,
during my sleeve, she used a retractor. So yeah, I mean, it's pretty
I didn't
cool to
even have to use a
know.
retractor on you.
Yeah. Like
I mean,
wicked.
what? And I'm like, yeah, it's pretty beautiful. I don't think I put a retractor in. I might have as it went just for the filming purposes, but I'm like, man, you're giving it to me so pretty. So here's what we're looking at. This is your esophagus. So I'm just carefully taking off some of the tissue around your esophagus because up in here this is now I'm looking up into the chest. So I don't want to go too deep because otherwise I'll be looking and making eye contact with the lungs or with the heart, and we don't want to do that.
Okay.
Sometimes I have to, because I just have to mobilize it. This right here,
Yeah,
this is
what
your
is
aorta beating. If you appreciate, that's your aorta right there. Your anatomy is so pretty. I just can't get over it. This muscle here, that is the right cruce of the diaphragm. This muscle right here, this muscle right here, that's your left cruce of the diaphragm. And you're starting to probably now that I took the that saran wrap or that film off of it, that's basically what I'm doing. I'm taking the film off of it. But now that I've done that, I'm sure you can start to appreciate the size of this hole.
Yeah.
Yeah.
So basically, when the esophagus comes out, the diaphragm muscle should go, tight around there. Yours is pretty big hole. You can see your esophagus kind of just flopping in there. You see this big hole around it.
Oh my
So,
God.
yeah, you can appreciate, all of that.
Oh,
So I'm going to take down all these adhesions here, and I'm going to get this cleaned up. Let me fast forward a little bit here. It's just kind of more of the same. I'm making sure that that is just perfectly dissected and just kind of perfectly open there. And now I'm going to close it. So
that's a
this suture,
huge hole, guys. Like
this
if you're
huge
online,
hole.
this is
You need to
insane.
screenshot and like print this for your wall.
Print this. How in the world were you just, oh yeah, this is totally normal.
Totally normal.
This
That's
is
well, and that's something while you're sewing, we can kind of watch you sew here. But
Yes.
interrupt me if you need to. Um, talking about the symptoms you were having, I was at a conference like last week, and it was people were talking about like what is kind of normalized as side effects and symptoms and things. And I think a lot of people are just so used to feeling not great that they think that
Mm-hmm.
that's the norm. And sometimes we have things that don't feel great, or you have pain, or you have whatever, and maybe that is like, but let's like look into it, because for the most part you shouldn't be feeling terrible all the time. And so,
and that's the thing that's kind of misconception for me is like I didn't feel terrible.
yeah.
Like I just was uncomfortable once a week and that was that. And but
Yeah.
like and that's actually no, if I really be honest with myself and look back, like there's times where I ate and I would have to like put my hand like on my stomach and just kind of rest it to like because it would be really like pressury. Like I could
Yeah.
feel like it would take a while for things to move. Uh,
But
so
I
and
think
that's
sometimes
kind of
people do
interesting.
that to the point where it's like you feel like that's normal, and
Yeah,
you've adapted to it. So you're
I
like,
did.
oh, it's not that bad. I just do this, I do that. And then like maybe if you start to kind of talk through that process of like, oh wait, that's nuts. Like I shouldn't
Mhm.
have to do, to do X, Y. It's the same thing with like other pain. If you've got shoulder pain or back pain or whatever, or untreated things, like, yeah, that's not like you again, you kind of get used to it or you adapt to it.
Yep.
And then once it's gone, it's like, oh my God. Like you don't know how. I think a lot of people, and I think in general, people who have, different diseases and disorders and things, like you don't know how bad you felt until you feel better, and then you're like,
Yeah.
wow, I really felt bad.
Yeah, because like thinking about it, like in the last couple of weeks, like when I drink or eat anything, like I
Yeah.
don't feel any pain,
Yeah.
no pressure, no like I'm not having to hold my side or anything.
Yeah.
So
And, a lot of, especially the lap band patients, they are functional bulimics, is what I call them. And they're like, yeah, I guess I am. Because you're like, oh, I just know what I need to do is I just need to go and like vomit and just, oh, I get that sensation. Hold on, let me go vomit real quick. And then it's like, oh no.
Yeah.
Now, taking it back here to me closing this, doesn't this look so pretty? Like, look how good your diaphragm looks. How does this look to you, Mel? Like when you're seeing, like you see me pulling muscle of the diaphragm. This is why you have that left shoulder pain, because I am suturing with this. It's kind of barbed, if you will. It's not like a barbed wire, but you can see like the barbs in there.
yeah.
And this is permanent because again, I don't want this hole to pop open either. Otherwise, you'd have an acute herniation again of your stomach up into your chest. But what do you feel? What do you think when you see this? The muscles coming together.
It is freaking me out. It is wild because I'm just had no clue like that this is what I needed. Like oh, like it's just crazy to see like things are actually going where they're supposed to go.
Well, look how many sutures. So sometimes I do this and I'll throw one throw. What did I throw? 1, 2, 3, 4, 5 throws. It was that big. And now I'm going to go back down. So all of this here, that's your esophagus. So I now have about 4 centimeters of esophagus in your abdomen. And then you can see that it looks a little different here. Like there's fat here. That's your stomach. So this is the GE junction between your esophagus and your stomach. That's that kind of the junction between them. And now you see, this diaphragm muscle is now going to be nice and hugging just around the esophagus, just like it should be.
And why was my left shoulder hurting?
Because I don't know why, but like when you sew on the diaphragm here, it gives you referred pain to your left shoulder. So
interesting.
yes, so a lot of people are like, gosh, my left shoulder blade is killing me.
Yeah.
So
and it was for a couple
days. A lot of throws in this bad boy.
Yeah, I remember just looking at Ashlyn when I was walking and pacing the hotel room, and she's like, "Are you okay?" And I was like, "This shoulder, man, like what is happening?" And she's like,
"This is what happened. I had
this is what, yep.
You're ready to come throw bows here.
Okay, so now what we're going to do is now I'm going to re-sleeve what will become your sleeve. And so I'm going to take your stomach from, like I said, it's about 3 times the width it should be and what it should have been made the first time. And I'm going to take that down to the correct size stomach pouch, down to the size of a thumb. So I am going behind your stomach here. Now look at this, Mel. Look at this. I could not get over this.
Oh my
Look
God.
how wide this is. Look how wide it is.
That's my stomach.
That's your
oh my God.
Stomach, your sleeve stomach.
Oh boy. Yeah, that's not supposed to be that big.
That's so wide.
So you use what?
So this is 60 millimeters. So it's supposed to be, and I think the perfect size is about 35 millimeters. This is a 60 millimeter stapler. I have it hubbed, and you'll see here I had to use 2. So yours was, I'd say, about 75 millimeters in width when it should have been about 35.
Whoa.
Yeah, it's just so wide. I mean, it's like they didn't remove that much the first time. So what I'm going to do is I have to staple this in 2. So everything that is down beneath this stapler, everything down there will become part of the bypass stomach. So all that is going downstream like we talked about with the juices, and now food comes down the esophagus here, and then I'm going to reshape what will become the new thumb-sized pouch. So you still see there's a lot of stomach that still wasn't even divided with that one 60 millimeter staple lid that I held.
There's still more there, guys.
There's a lot more there. Yeah. So now I'm going to get that completely. Now I have it completely dissected in 2. And now this is something else that I realize is very important when I'm doing a revision that I didn't always used to do, but now I realize is that the key to success. You have this very thin layer of fat that is right there on top of the pouch. And I had to take down that kind of adhesive band and open that up. I never used to do this. I had a patient who did have a problem with it. It actually caused her to have some vomiting. It looks innocent. You wouldn't know it, but you see how like that's opening up. That little bit can really cause patients to have a hard time. So I learned from that patient, and now forevermore I go all the way down and I just take off all the fat so that it doesn't tether it and cause you to have vomiting or any issues. So I'm making that nice and wide open.
Yeah, and I haven't even felt nausea, to be honest with you.
You shouldn't.
I haven't even had to take any Zofran or anything. It's only been Gas-X. That's all.
Perfect. Yeah, I realize this is the key to success in doing these so that you have, like, from that regard, like you're saying, like a seamless, you see how now it looks.
Yeah.
You didn't think it looked bad, but
no, because you still want your stomach pouch to be able to expand. And I feel like that's probably what that kind of prevents. It's almost like a saran wrap again.
Yeah.
Everything is saran wrap.
The dietitian speak.
Yeah. Plastic wrap, I guess Saran is the brand. But yeah, like it had that so it couldn't expand when food went in there and then go down.
Exactly. So now what I'm doing is I'm re-sleeving what will become the new thumb-sized pouch. So now this is a beautiful straight opening from esophagus. It makes this transition here to stomach pouch. I'm advancing a sizing tube. So I'm doing this over a 32 French sizing tube so that your stomach will be Goldilocks size. I think 32 French is the exact size. Look at everything to the right of the stapler that I have to remove that should have been removed the first time. Look at that.
Whoa.
And it's the fundus.
It is the fundus. So you had a retained fundus. Great point.
What does that
That
mean?
fundus wasn't dissected off of its splenic attachments the first time. That was virginal territory. So I had to take down the attachments or the blood supplies called short gastric arteries and vessels. Those were not touched in you. Now, granted, I do want to give credit that your surgery was done 11 years ago. There really wasn't a great consensus. You were one of the first people, the earliest adopters of having the sleeve. And if you've had your sleeve over a decade ago, it's going to be too big because we wanted to make sure that it was really safe. So people erred on making them a little bit bigger. But that shows you like, well, a little too big here.
Yeah.
Little too big.
Well, and it just shows you from 11 years ago to now, like how much has changed and evolved and how much information we now know. Because I'm sure Dr. Patterson probably does it more like this than she did before. Like,
right.
You know, she's grown and learned too. So I'm sure that it's different. So
I mean, I have too. I've learned so much in doing these revisions. So you see that, obviously this is really wide. I will admit when I first started doing sleeve to bypass revisions, when people started to have a lot of issues with reflux, we were really reluctant to go in. It's like, it's a revisional surgery. Try the Tums, try the Prilosec, try the meds, try the Carafate. And it wasn't working. And so when I first started doing revisions, I never re-sleeved what will become the pouch. So I just cut them in half and I hooked up the small intestine and I never took this part out.
Oh, interesting.
And so I always like, oh man, like now I feel like I got this so perfect. So sometimes I do feel like I left a little bit. I personally will admit that I left this piece. Now yours was really big. I don't know if I would have left. I don't think I would have left all that, but yeah. So that's
you found us at the right time.
Yes, you found me. I feel like I don't want to say perfected, but I feel like I've really mastered the nuances of all the, things with it.
Is that my spleen back there?
Yes, this is your spleen. So that's
Holy shit.
that your stomach was attached to there still. So I fast forwarded through some of that. That's where I had to get this little piece that I'm taking off. I had to get that off of those splenic attachments. The spleen and the fundus or the part of the stomach, they spoon actually.
So they kind of
it's very sweet there as well.
They kind of hang out together.
Yeah. Okay. And then here it comes. She's gonna clamp down and it goes and then it's separated. That's the sound it makes.
It does make a sound. I know you can't hear it, but that is absolutely the sound that it makes. And then voila.
Oh my God, there it is.
There it is.
What's funny is then it just kind of hangs out for a little while. I don't take it out of the stomach yet.
It looks like abdomen because if I stretch out, then the whole time, so we blew you up with CO2 gas and the whole time it will leak. And so I do that at the very, very end. Yeah. So I note to the team that you have a Raytech still inside and you have your specimen inside.
Yep.
Okay, my God, that's crazy. It's just hanging out. My baby tummy just hanging out in there.
All right, so now what I'm going to do is I am going to make the gastrojejunostomy, or I'm now going to connect this little thumb-sized stomach pouch, which is now so cute and so perfect.
It is. I'm not gonna lie, it looks really cute. It's like this little tiny guy.
It is so your pouch looks so good. Your esophagus looks good. Everything looks so good. Your anatomy is gorgeous. I can't say that enough. And now you see this pink piece here. Remember in the very beginning, I sewed a marking stitch to what will become the roux limb or the piece of intestine that I'm bringing up to join with the stomach pouch. So I'm now basically joining these two together. So I'm going to basically use these sutures to make them come close. Let me fast forward here. And then I'm going to tie this down and that's going to bring it together. And then I'm going to make a small little hole in your stomach pouch and a small little hole in the side of the small intestine. And I'm going to put the stapling device there to make those two things become one.
Is crazy. So this is where the junction of like where my food is now going to go into the small intestine. This
Exactly.
is
So
that
when you
area.
swallow food, it's going to go down the esophagus, which first is up in your chest. It then goes through that hole in the diaphragm, which is now the correct caliber or diameter or size. It
Okay.
goes into the esophagus that's now in the abdomen. It goes into the thumb-sized stomach pouch, and then it's going to go directly into the small intestine here. So food and drink will take a nice straight shot now. The pylorus, which was the part of the sleeve stomach that was causing you to have the most issue, that part is now bypassed. So that bottom part of your sleeve stomach is now no longer seeing and storing food. Things are going to come straight on through here, and it's now going to be converted from a high pressure system back up in the wrong direction to a low pressure system down the correct way from basically north to south is where food is going to go now.
Okay, because that my whole anatomy for pooping is very weird now. I mean I poop every day, but like it's not normal poops. These are snake poops, and I've never had snake poops before, so this is
Wow, really?
interesting. Yeah,
That might be from the diet that you're on.
probably.
It sounds pretty good though, right?
Yeah, I mean it doesn't it just yeah, it just goes. It's just quite interesting because I'm like, okay, so now it's time, and you can feel it right away. You're like, all right, it's time to go to the bathroom. I can't be holding it anymore. I used to hold it sometimes and be like, all right, we'll wait till whatever's done. But nope, not now.
There you go.
We're
Well, that'll change a little bit. That's part of the early post-op. But things aren't being obstructed or kinked or things are going through easier now. And
yes.
you see here, I'm using the stapling device. Again, that's the stomach pouch is on the left of the stapler, and then on the right is the small intestine. And I'm going to make your anastomosis opening around 35 to 40 millimeters. So that will be the diameter of the new connection between your pouch and your small intestine.
Okay. So now that I'm on day 17, I mean, I know I have the guide, but can we tell people what should I be eating around this time frame?
Sure. So, that's an awesome question. We do a diet progression because you see there's lots of stapling and I'm sewing, and you want to make sure that areas heals because you don't want to have any leakage. So there's really no movement you could do that could screw something up. But if you were to eat on post-op day 1, when you're supposed to be on full liquids or protein shakes, if you were to eat a piece of steak, you could potentially,
Gone.
not that you'd want to, but if you were to do that, you could disrupt that connection. So yeah, you don't want to do something like that. So the diet, we do a more liberal diet, I think, than other people. After 1 month, you're already back to regular food, but that very first day in the first week, you're going to be on full liquids, and then you're going to go on to pureed for week number 2. And then where you're at right now is that lovely soft food phase. So that's weeks 3 and 4. And then you're already onto regular food after that. High protein, low carb, little to no added sugar.
Yeah, because I got a message today because I ate chicken yesterday.
I saw
And
that.
and one of the girls messages me and she's like, "You can already eat chicken? Are they progressing you too fast?" And I was like, "No, like if you think about it, like I'm in like the soft food section, and as long as I chew it up, it becomes puree."
Yeah.
So it's like I was able to eat a good amount of my chicken yesterday, and then I mean that was for lunch and dinner. So um it was interesting because it did nothing hurt. Everything just did it was supposed to do. I am a little more cautious than most people. I don't stray away from the diet. So I look at that guide almost every couple days and I'm like, all right, where am I at? What can I have? Because I do get nervous even when I had the sleeve. I remember telling Dr. Patterson I was really scared to move on to solids because I just didn't want any leakage. And she's like, "Oh, girl, you're on a month. You're already a month out. Like, we're not worried about leakage anymore. Like,
No.
if it would have happened, it would have happened already."
Yes.
And I was like, "Oh, okay," because I was like, "I can't have bile all over my organs. This would be awful." And she's like, "That's not gonna happen."
It's not going to happen. No.
Yes.
In
So
fact,
I'm
once you're 5 days post-op, knock on wood, you're typically outside of the range. So you're already
good.
sitting pretty even with this procedure at day 17.
Nice, nice. Okay, good, good. Because like I won't introduce probably steak for until I'm like outside of the month, but like chicken, I'm gonna eat all the chicken I can. I basically, what I've been doing is like protein shake, yogurt, and then I'll have like chicken salad. I can tolerate beans now just fine.
Great.
So I'm getting it. I'm basically drinking like 2 protein shakes a day, and then the rest is just fill-ins of solid/mushy foods.
I
So
think you're doing fantastic. And the fact that sometimes chicken is harder to tolerate if it's not really, really, really moist. That can be tough there too.
yeah, I always dip it in something, and then I chew. So
Perfection.
100%. So this is where everything combines, guys. If you're watching online, this is just fascinating to see my stomach attached to my smaller intestine. Like, wild.
It is. And right, yeah, it's just like you said, right now what I'm doing is I'm hand sewing that connection between I'm going from the small intestine and I'm coming through and I'm sewing that opening closed into the stomach there. So I'm just making sure that these things are closed. And we talked a little bit about, the potential complication of a leak. And I am going to do, once I get this thing completely closed, in 2 layers. So right now I'm on the first layer. I'm going across, and then once I go back after I do that, I do test it. So we're going to see a leak test where I actually
Cool.
is like looking for a hole in a tire. I'm gonna check all that out. I'm gonna fast forward here. Um,
Yeah, everyone has asked me, did they do a leak test? And I'm like, I'm sure Dr. D did. Like, I wasn't awake for it, so I don't know, but
Right. So I do a leak test while you're still asleep in the
yeah.
operating room. Exactly. And so there's some surgeons that I would consider still old school if they're still doing this that would do a leak test in radiology. Did you have that after your sleeve where you drink contrast and then they shoot an x-ray live to see if the contrast leaks outside?
No, no.
Yeah, that's very old school. I don't think there's very many surgeons that still do. It's called an upper GI swallow study. And again, it's done in radiology. I don't think many surgeons still do that, but uh,
It just
I don't.
seems like extra work for both people,
Well, the
you know?
reason why I don't think you need to do it, first off, you have to do that. You'd have to have your surgery in a hospital. But second of all, it's extraordinarily nauseating, and I think that it just slows your ability to advance and get onto the diet and start doing full liquids and all of that. And the contrast is a laxative, so it gives you pretty gnarly diarrhea too. So,
Lovely. Yeah, I
yep,
don't need any more
no issues.
diarrhea-ish stools.
No, we want to keep everything as regular as possible. Okay, and then I'm now sure on the back side, so I'm just kind of reinforcing that to make sure, again, this needs to be a 360-degree airtight seal.
Well, and it's crazy, guys, because you can see my liver on the left, you can see my spleen, you can see my stomach that was taken out, just hanging out back there. Like, it's way different when you know it's you.
I know.
Because like I don't get squeamish, but once it's me, I'm like, oh, that's interesting. I was telling people because they're like, well, what hurts the most? And I go, it's not really hurt. It's like, it's almost like I can feel my insides. Like I feel sore inside, like an internal soreness.
I'm sure you do. I mean, there's a lot of work in here. Like, look at all this cutting and suturing and, oozing and taking down the attachments or adhesions and scar tissue and yeah, there's a lot that went on. And for these 4 little tiny incisions, it's almost like, oh wow, I didn't realize that all all that was happening in there.
Yeah. Like at first when you were showing us the videos, like I teared up when the first one, when I saw my stomach attached to my abdominal wall. That
Yeah.
one really got me. And I was just like, oh my God, like this is why everything's been happening. Like this makes more sense. And then I got really excited when you said there was like barely any visceral fat. And I was like, yes, we have a good part of this. Like my insides are
Oh
beautiful.
my
And
God.
that makes me very happy because I know damn well 11 years ago it was not pretty, right? Like there was so much visceral fat in there.
Oh, I know. I mean,
So,
like I said a million times on this, like I know you don't watch, you're not at people's insides all day, every day like I am, but
right.
your surgery is just, I'm just like almost like just watching it over here on the screen. I'm like, okay, come on, focus. You're supposed to be. Most people aren't going to find this as entertaining as I'm finding it. But right now, you might not have appreciated it, but do you see that I just pushed a tube down? So the tube came back down again. It's way down there. And so
Yeah.
now I'm pulling that up so that the tube is just barely past the anastomosis. That's the tube I'm going to utilize here after I finish sewing this second layer on the way back. I'm going to utilize that to do the leak test. So that tube acts, it does a lot of things for me. It helps me to size it, and it also helps me to do a leak test, because I'm going to explain the leak test that I can get very precise with the amount of millimeters of mercury or pressure that I can put into the pouch.
Oh,
Um,
wow.
and so that I know exactly that I'm really blowing it up under a lot of tension, so that if there's any bubbling of any type, it'll it'll bubble into the fluid that I'm going to have the anastomosis submerged under.
Wow. I like that you do it this way.
Thank you.
Yeah, because like I to know that my size was like my size of my sleeve was just way too big, and to see it
Yes,
be small and like how much you're doing like to make sure it doesn't have any leaks. It feels good to be taken care of, and that was the I will make a video about this. Like I think you were probably the first person to ever be like, you literally heard me and you listened, and then you're like, we have to fix this. Like there was no ifs, ands, or buts about it. And that was like the first time I feel like a medical doctor really saw me.
man.
So it makes me teary. I love it right now because
Yeah. Well, oh my gosh. Well, I appreciate your kind words, and I think that that's why, gosh, like I'm so passionate about this, and I know you've said that before, and I know you know that. It's just because, like, oh man, like you're messed up. Like, let me fix it.
yeah,
And, like I want to help. I do. I mean, I would think that's why most people do in the first place say, I'm going to go to medical school when I grow up. It's like, I do want to help people. And this is this one really weird, nuanced thing, that I've become kind of obsessed with. I know that I can help a lot of people. So if you happen to be listening to this podcast, I would love to just to have a conversation with you and tell you what I think is happening to you based on your symptoms, and if you're vomiting or if you're having pain or if you even just didn't experience the weight loss you wanted. I don't think that that should be undermined as like, well, I don't vomit. I'm actually pretty good. Well, hell, maybe you don't vomit because your sleeve's huge. It might not be twisted,
yeah,
kinked, and held up to the abdominal wall. Um, but I would love the chance to even do any type of imaging evaluation, like you said, to know what's going on. And so now the anastomosis is done. You were a little oozy right there. So I'm throwing another stitch to help to just take care of that little ooze, because obviously it needs to be perfect. So I
that's
am
right.
throwing a figure of 8 suture. So it's going to be kind of like the letter 8 there. And then that is going to stop all that up there. There we go, and the bleeding will stop. So everything lines up really nice, really, really straight. I'm really happy with that. The GJ anastomosis looks great. I am kind of dabbing this off. And then I have one more thing to do before I do your leak test. And that is, remember earlier with the permanent suture, I was closing one of those potential internal hernia defects. This
Yeah,
is your second one. So that whitish organ, that is your colon, your transverse colon that goes across your abdomen. And I'm having my assistant lift that up, and there's so little the fat handle is so funny to me. Like, I know. Um, so they're gonna hold up this area right here. And then what I'm going to do is I'm going to start down at the base, and I am going to with the permanent suture with the ethibond, you see this big hole here, down here. Intestines could
yeah,
potentially, is kind of where I'm moving the mouse. The intestines could potentially go into this area, and then they could get stuck in the left side of your abdomen over here. If you were to have a bowel obstruction or what's called an internal hernia, this defect is called Peterson's hernia defect. And this accounts for, in my clinical experience, 99% of all internal hernias occur through this opening right here. They sneak behind that piece of intestine we brought up because this space wasn't here before I brought that up. And so if they get stuck, incarcerated, they could even get strangulated if their mesenteric blood supply is involved, and that would be horrible. So I'm going to close that up just like I did with the first one.
Yay.
And obliterate this in 2 layers here.
Wow. So you made it to where I should not be getting hernias.
You should not. You
I should not.
And the thing about you, which makes it a lot less likely to get one, is that you're already so thin. I can see exactly where to go. Now, sometimes in a perfect storm, if I'm sewing, basically you can see like fat to fat here. I'm sewing mesentery to mesentery. And sometimes if your mesentery is really, really thick and then you lose that, that might make just a perfect storm where that gaps open a little bit. And then that would cause, that an opening where the intestines could snake through. But yours, I know exactly you can't get any skinnier than what you are on the inside. So we already kind of know that as well.
How funny. I never thought I'd be skinny on the
You're so
inside.
skinny. And you are skinny, period. And you're going to get really, I predict, because you're in the 170s now?
Yeah, I'm 175.
You're 175. I bet you're going to be, how tall are you? Okay. I'm going to bet you're going to, your new set point's going to be 150 after this.
Okay.
You heard it here first. Whenever I'm right, and I think it's going to take you less than 6 months post-op to get there.
Look at her. Oh my goodness.
I'm
And that's
throwing
the
my
thing.
bets.
Yeah, because like that, I want to put on some muscle too. So like once I'm cleared, guys, you're gonna see me in the gym, or really not even in the gym. I'm gonna do some different kind of things. Like I'm gonna do some Pilates, and I'm gonna be doing some pole dancing, and like just really have fun with it. And just see what I can do, because I now know this is like a second chance for me to get to where I want to go.
Absolutely. I think it's going to accomplish all things. No more nausea. You're going to feel good. And you're going to get those just the last couple pounds off, and you're already doing all the movement and all of that. This is just going to lead to it. So you see that whole hole there is now closed.
Yeah.
The door is shut. Nothing is snaking behind there. I really went for it. I really went in there.
This makes more sense why I would like, my insides are sore. It's like, look at what she's doing, man.
Pulling. Yeah, I did a lot of stuff here. So that's all closed. So now what I'm going to do is I'm going to do the leak test. So I am using a previously used stapler load as a clamp. So I'm going to clamp beyond this. That puts it even under more pressure. And then you see the tube that it's on the inside. You can kind of see the tip of it whenever I'm moving around there.
Yeah.
And what I'm going to do is I'm going to have the anesthesia provider, they're actually going to open it and they're going to squeeze as hard as they can to 35 millimeters of mercury of pressure. So they're putting it under as much pressure as they can. You see how it just
whoa.
And now I'm like carefully, my assistant is drizzling water saline over the connection. And if there was a leak, you'd see bubbling.
See the bubbles.
You would see the bubbles. Because you see I'm putting it, that's a lot of pressure. There's nothing that you could really even eat that would put it under that level of pressure.
Good. Okay. That makes me feel better when I drink my protein shakes.
And so I'm looking at all the.
Well, that's crazy. You can just see like all my insides just like almost looks like it's getting cleaned.
Yes.
And, and like, yeah, no bubbles, guys. I'm passing this leak test very well.
Yep. And so now I'm having them decompress it. Now you see them blowing your abdomen up with CO2 gas, so there's a lot of gas there. I also blew that up. So if you're like, oh, I got a burp, oh my God, it's because even though they suctioned out, there's so much air that we put on the inside. So that's also
Yeah.
why it's like, oh gosh.
Well, I don't know if they told you or not, but when Hannah was helping me when I woke up, like I felt like I was gonna puke, but it was just burp. And it was like they said I made the loudest burp they've ever heard. And they were all excited about it. They were like, yes, get the burps out. Like, and it was, I just kept burping loud and loud and loud. And they're like, get it out, get it out. I was like, all right, I guess burps are good today.
Burps are awesome. Anything you can do, either burp or fart, just get it out. And the quickest way to feel better is the shortest distance is to go back up and just kind of burp it out.
Yeah.
And then I saw when I was doing the leak test, it looked like it was just a little bit tethered. And so I took off that one last little cell layer there so that that again is wide open.
Yeah,
And
no
so
more twisting.
no twisting. I was like, no, this thing, now you can see that there is absolutely nothing on there. That is as straight as it gets. You see how
Wow, yeah.
So yeah, I wanted to make sure that that was perfectly straight. Everything would go down beautifully. This is it just looks really, really great.
It really does now that I know the anatomy well. Like I can see like how my esophagus is in my like abdomen, and I can see how my stomach is attached to the small intestine. Like this is wild.
Yep.
And
I'm
then
so happy with how straight that is. And then I'm now going in with a clip device. I'm just going to put a few clips in any areas that look like it's like a little oozy there, just to make sure that you don't bleed. So that would be another early potential complication is if you bled inside of your GI tract, you would either vomit blood or poop blood. Pooping blood is not that uncommon, especially because you see we're stapling and things and you saw a little blood in there. Blood is
yeah.
also a laxative, and so it comes out. So if you have a little bloody diarrhea, that is actually normal and common, not a big deal unless it's bright red and it's not stopping. And then also you could bleed inside of your abdomen. That's an intra-abdominal bleed. And so I'm trying to make sure that everything is what we call hemostatic dry. There's no oozing, bleeding. It looks, really clean and nice.
Wow, look at that. It looks good.
I think so too.
It really does. Like knowing what it looked like when we first started this episode, like
My gosh, I know.
it's just wild.
It is so wild. So now this is why you had right-sided pain. So I'm going to end the procedure explaining all of that. So I am also suctioning out a lot of that fluid I use for the leak test. I do sometimes think that patients definitely have gas pain, but they also have some retained fluid. I try to suction it out, but sometimes that little bit of fluid, I think, also gives you that irritation internally. And your body will reabsorb that saline. It's not a big deal. It's physiologic and all of that. But I'm trying to get every little ounce of fluid out to try to expedite that healing and recovery and discomfort that you might have. All right, so now I'm getting all the fluid out, and I'm also going to look at the JJ anastomosis one more time. You're a little oozy on that staple line, so I just put a little clip there as well. I'm super happy that everything is dry.
What happens with the clips? Do they just stay in me?
They stay in you. Yeah, they're made of titanium. That's very biocompatible. The same material that the little tiny stapler materials are made of as well. All right, so now what I'm going to do is I'm going to suction out that last bit of fluid right there in your pelvis. And then finally, I remove that piece and I put a deep stitch, and there you go. And it's out. And I pulled that out and took out that big chunk of stomach. I took out that Raytech. I put a deep stitch on that right-sided incision, and that will hurt for a few days until it either pops or absorbs.
Okay. So that makes way more sense because, like, guys, if you didn't see on Instagram, like, I was basically talking to Dr. Dovec through a video and was like, I hope if you're watching this, tell me what it is because, yeah, that right side was just a little more sore than I expected. And it makes more sense now that, like, you had to do a little bit more repair there. That's where my stomach came out of, right? Too.
Exactly. So that big
Yeah.
piece that we're showing, the extra sleeve, all that stomach, I had to pull it out, and then I had to put a deep stitch there to pull that muscle and fascia back together. And yeah, so essentially like I'm pulling your six-pack muscle together, and I had to thread a needle through it too. So
This makes
ouch.
way more sense.
Yeah, now
Way
you know
more
you're like
sense.
it's just like this weird tugging. Yeah, because I'm like yanking muscles together with a
You
one
legit.
like a stitch in your side. That's what you had.
I totally did. My goodness. So guys, if you've learned nothing from this, but to go get checked, go get checked. Things are not supposed to be like, you're not supposed to puke once a week or once a month. You know, if you're feeling nausea, if you're having troubles with anything, just go talk to your surgeon or just go message Dr. Dovec. Like,
Yeah.
she is here and willing to help you no matter what state you're in. Just make sure you have your insurance information ready to go. And she'll help you. And if it's not for a surgery, maybe you just need a GLP-1. They help you with that too. So it's kind of crazy. Dr. D has made it to where she can help you with anything weight loss related, and I just love it. It's
And I don't know if you
amazing.
know this. I don't know if we said this on the other podcast, but some people either don't have insurance coverage or they have it, but they exclude. We know this whole thing with access to care. Our self-pay sleeve to bypass with hiatal hernia repair pricing is the lowest in the United States. I don't know if you knew
It
that.
is. So I knew that personally, but y'all's didn't. So you need to check into that because you don't have to go to Mexico anymore. Like, Dr. Dovec has made it to where it is affordable, to where you can just get yourself helped without having to worry about going to another country to get this done. Like, America, yes, our prices are pretty insane, but she made sure that like it's doable for the regular Joe. So I think that's something that we should highlight because it's very important because access to healthcare is insane in this country. So she's made it easier, so might as well use it, right? So go to Body by Bariatrics, go follow us on all the things. I'm going to have everything linked in the description. Tell her I sent you and she'll definitely take care of you. So
Absolutely.
thank you so much, guys, for watching this. You know the drill. Make sure you get that protein, the water, the sleep, the movement, the therapy, and lastly, but not least, the vitamins. Whether it's from Dr. Dovec, she has her own line. I use ProCare as well, been with them for a very long time, but I've tried both because I got a little goodie bag with her stuff and they're great. So might as well use whatever works for you. And last but not least, guys, don't be an asshole to one another. Have a great week. Let us know if you need anything.
Thank you, Mel.
Thank you.
Thanks for tuning into our Sleep Life podcast. If you found this episode helpful, make sure to subscribe, leave a review, and share it with someone that needs it. Remember, small, consistent steps create lasting change. I'll see you on the next episode.